Okay. So hi guys, I'm glad to see you here back. Glad to see this thing becoming a recurrent thing. Glad to see you're still showing interest in this. And I'm especially happy because today I won't be the host. I will just pass pass the podium to one of our people to share some insights with you on vulvar intraepithelial neoplasia. And before that, I just want to, remind you of some housekeeping things. Our next regular meeting is going to be on a Saturday again to accommodate time zone differences on July 6th. It's going to be about pink renal tumors. I'm going to do a second part, discuss some other, because in our first PRLUSS meeting, we discussed some more common pink renal tumors. And in our second session on this topic, we're going to focus on some molecularly defined renal tumors. I hope you're going to enjoy it. I have some pretty neat cases to show. And on Saturday, another Saturday, July 20th, we will have another one of our own, and a dear friend of mine and former colleague, Aminia. She's gonna walk you through papillary lesions of the breast. So with that, I would like to introduce Dr. Felipe Ruiz. He's a PGY2 APCP resident at the University of Miami in Miami, Florida. And he will be talking to us about vulvar intraepithelial lesions. And he promised to go through all the entire spectrum of them, so it's gonna be nice. I'm glad to see he took the initiative and asked to, present this. The whole purpose of this is for you to have an environment to practice, because this is very informal, and I think it's a good way, especially for junior trainees, to practice their presenting skills. And it's that informal that I'm going to show you my cat, which is here joining us. So yeah. So let's pass the mic to Felipe. Felipe, wait a second. I'm gonna stop sharing my screen. And pass the mic to him.
Thank you so much, Mirona, for creating this space and for giving me the opportunity to present. I agree with you. It's an amazing opportunity to practice, to share knowledge with other trainees. And as you mentioned, I'm going to go over the vulvar intraepithelial neoplasms. And my name is Felipe Ruiz. I'm a PGY2, soon to be PGY3 at University of Miami. And let me share my screen. Is everyone seeing the correct screen?
Yep, I'm seeing it. Yep, it's fine.
Okay, should be good. Right, okay. And the meeting is still recording, so I think we are good to go. So as Mirona mentioned before, I will present the vulvar intraepithelial squamous lesions. I'm very fond of GYN pathology, so this is a topic very interesting for me. So I will start with a case that we had in-house, which sparked the interest to create this presentation. And then moving along, I will go over the overview of the histological molecular subtypes of vulvar intraepithelial lesions. I will share a diagnostic algorithm and share some conclusions about them. I think this presentation will be short and sweet, to the point of for any trainee or practicing pathologist that encounter any like a vulvar lesion can be able to approach it in the future. So regarding our patient, it was of a 65-year-old postmenopausal woman that had a long-standing history of pruritus, irritation, and pain in the vulvar area. Physical examination revealed a patchy, discolored, thinned area in the vulva. Biopsy was taken and the histologic sections show well-differentiated squamous mucosa, but with a prominent atypia in the basal and parabasal layers. Here is a closer look of what I was mentioning. If you can see, if you are looking at this at low power, you might catch it, but it's not the classic vulvar intraepithelial neoplasia. And actually, for me as a trainee, I missed it because I didn't catch the atypia in the basal and parabasal layers early on. But I will keep talking about it. More sections of these of other areas of this patient. Here, the atypia is more prominent. So like the differential diagnosis in this case, of course, first we have to think about the HPV-associated vulvar intraepithelial neoplasia or the usual VIN. Next, we think about the HPV-independent differentiated vulvar intraepithelial neoplasia or differentiated VIN, DVIN. And we have more rare lesions like the HPV-independent differentiated exophytic vulvar intraepithelial lesion or DEVIL, and the HPV-independent vulvar acanthosis with altered differentiation or BAD. Coming back to our case, of course, we did a P16, which was negative. I didn't have the slide, but we also performed a P53, which showed overexpression in the basal and parabasal layers. I will come back to this later. The final diagnosis was HPV-independent differentiated vulvar intraepithelial neoplasia. So before coming back to our case, I will do an overview of the subtypes of vulvar intraepithelial lesions, starting with the HPV-associated vulvar intraepithelial neoplasia, or UVN. This accounts for the majority of squamous intraepithelial neoplasias of the vulva. And well, in some papers, actually, I've read a paper recently that's saying that it could be like the same as the DVIN, but I think more studies need to clarify. But right now, what is in the WHO is that it's the majority. High-risk HPV is are the cause of HSIL, and HPV-16 is identified in 70% of cases. Cigarette smoking and immunocompromised patients are epidemiologically associated with an increased risk of these lesions. So the VIN 2 or 3, which is the same as HSIL, has two described morphological patterns, which are the basaloid and the warty type. But as I was talking with Dr. Pinto, my mentor, these are overlap between this pattern is frequent, and actually it's rare to see one or the other. We usually see both. The basaloid HCl will have basaloid cells with scant cytoplasm replacing the epidermis, and the warty type will have epithelial thickening with papillomatosis, pleomorphism, colocyte-like changes, and multinucleation. Here's an example of a predominant basaloid morphology where we see these basaloid cells with scant cytoplasm replacing the whole epithelium. And the epithelium is thickened. This is important later on. And here we see a predominant warty morphology where we see the colocyte exchanges, but the parakeratosis and atypia goes to the top. We don't see any maturation. But usually in the bread and butter day-to-day cases, we will find something like this, where in some areas is basaloid, but other areas has the warty type atypia, morphology, I mean. And this, I think, most people will not have an issue as diagnosing as VIN without performing a P16 or HPV high risk inside of hybridization. But if you do perform a P16, you will encounter and you will find a block positivity, the same as in the cervix. And the prognosis of these lesions, which is very important, has a significant but low risk of progression to squamous cell carcinoma if untreated. Spontaneous regression is rare, and they have treatment options like topical imiquimod, local excision, antiviral treatment, photodynamic therapy, and laser therapy. And risk factors for recurrence is age over 50 years, positive cervical margins, large size, and immunosuppression. It's important that in the vulva, different than the cervix, we don't encounter a flat, low L-seal, which is very common in the cervix. VIN1 or L-seal is mainly limited to a condyloma, which will have the overall verrucous or warty architecture, colocytosis, binucleate cells, and when in the architecture will have acanthosis, papillomatosis, will have hyperkeratosis, hypergranulosis of the squamous epithelium. But no, it's rare to find an L-seal that's a flat type, like in the cervix. But here we see a classic condyloma acuminata, and if you perform low-risk HPV inside of hybridization, you will most probably find it dot positive in here. Moving on to our the diagnosis of our case, the HPV-independent differentiated vulvar intraepithelial neoplasia, or DVIN, is usually associated with chronic inflammatory vulvar diseases, and this is thought to be the main contributing factor, like lichen sclerosus. And TP53 mutations frequently identified, and this is very important for diagnosis too. Other mutations they have are cyclin D1 amplification and complete number variations in chromosomes 3 and 8. There's no specific biomarker for HPV-independent VIN like there is in the usual VIN. These lesions will have abnormal atypical keratinocytes confined to the basal and parabasal layers, and in a usually fully differentiated epithelium with parakeratosis, atrophic or acanthotic with elongated and somatocytic ridges, but most cases will have thinning of the epithelium. You may see abrupt abnormal keratinization or dyskeratosis, and the striking cytological and architectural typia in the basal layer with maturation is the most important clue in these cases. And the cytology, there will be enlarged eosinophilic atypical cells with large vesicular nuclei and nucleoli, prominent intercellular bridges, basal hyperchromation, frequent atypical mitosis. Here is an example of DVIN, where we see the maturation, but we see the striking basal atypia, and also with parakeratosis. Another example of a differentiated vulvar intraepithelial neoplasia, we can see the inflammation, band-like inflammation underneath, which probably was the driving process to move for this lesion to progress to this neoplasia. So it's very important, of course, like we will do stains, but to have in mind your differential and your H&E approach. So based just on H&E and morphology, the differentiated VIN, you will not see cholelithiasis. Usually will have thinning of the epidermis, and the basal and the atypia will be mostly confined to the basal and peribasal layers. In contrast with the usual VIN, where there will be cholelithiasis, can have thickening of the epidermis, and the atypia will be full layer. P53, as I was mentioning, is very important for the diagnosis of differentiated VIN. It will have abnormal nuclear P53 immunostaining in the basal and suprabasal keratinocytes. And this doesn't have any clinical significance, but I thought it was nice to mention that P53 overexpression suggests the TP53, that gene of P53, missense mutation, while 30% of the cases will show a null pattern where there is a complete lack of P53 staining, and this will suggest a nonsense or truncating TP53 mutation. And I'm not sure, like I will have to read more, but I don't think there are any papers mentioning the clinical significance of either of these. And rarely cases of differentiated VIN will have abnormal cytoplasmic P53 expression. And there's a paper, the paper that described these lesions originally, where they showed the wild type patterns and the mutant patterns of P53. So on the right, we see the mutant patterns of the intraepithelial lesions, where we see the basal overexpression, the parabasal and basal diffuse overexpression, the null pattern, which is the absent, or the cytoplasmic pattern. So it's very important to know that there is a cytoplasmic pattern, even though it accounts for less than 1% of the cases. It's not a staining mistake, it can happen. And the wild type patterns, it will have patchy basal P53 expression or mid-epithelial expression with basal sparing. So that's why it's really important to correlate with the H&E to actually see what is sustaining if it's the atypical cells or not. And they did this study where then the patients that developed squamous cell carcinoma actually retained that type of expression of P53 also in the invasive component, where so if it had a basal overexpression in the precursor lesion, it will maintain, and the same with the other types of expression. So these lesions behave much worse than the HPV associated. So that's why it's very important to catch these. Because they have a high risk of malignant transformation, and the progression to invasive carcinoma can be fast. These most carcinomas will be of the keratinizing type, and but non-keratinizing basaloid and warty subtypes have been documented. So it's important to understand that even though it looks basaloid, it can be a rare subtype, a rare morphology of this entity. Complete excision is the recommended treatment of this precursor lesion. So I wanted to show the study where they showed how the progression risk, progression-free survival of these patients compared to the high risk associated and the HPV associated and the HPV independent lesions, where we see that the HPV associated in the upper line, even after many years, most of these patients will not have progressions, but in the HPV independent, in the bottom line, will have a progression, and it can be fast. Now, the third group of precursor lesions are the quote-unquote devil and bad, which are much more rare. These lesions have acanthosis, papillomatosis, epithelial failure, but most importantly, they will lack what the other two lesions had, as the lack of basal cell atypia and the lack of any HPV-related morphology. There are not as many cases, but it's thought that an inflammatory stromal infiltrate can also lead to these lesions, which is found in 50% on the cases, but and it can be in a discontinuous pattern, but sometimes band-like. But the P value wasn't significant, so we need more studies on these ones actually. So all cases show P63 negative and P53 wild type immunohistochemistry. So this is the third group where we find lesions that are P16 negative and P53 wild type. And these lesions are usually associated with PIK3CA mutation. And HRAS is also one of the genes that are also associated. And the terminology for these are actually trying to move. There's not a consensus yet, but they want to call them P16 negative, P53 wild type lesions. And grossly, they can look like a mass, like a papillary mass, which looks worse than a papilloma. And actually, these cases are in-house, which were really nice. We see the prominent acanthotic architecture with no striking atypia and no HPV changes. And one of the clues is that we see pallor of the epithelium. And this is another example of this. Actually, the overlap between DEVIL and VAD is so much that they're trying to group them. But in this case, we also see the epithelial pallor, the lack of basal atypia, and lack of HPV-related changes. So the diagnostic algorithm for this, when you encounter a vulvar lesion and you're not sure if it's not classic for HPV, you think it might be something else, it's important to follow a diagnostic approach where you do P16 and to confirm the HPV-associated VIN, or if it's negative, then and you have the basal atypia, then you have to interpret the P53 to diagnose the HPV-independent VIN, and if it's wild type, then you can diagnose the DEVIL or VAD, or the quote-unquote P16 negative P53 wild type vulvar intraepithelial lesions. Back to our case, this patient, the differentiated VIN that I showed initially, did subsequently develop squamous cell carcinoma, which is this specimen, where we still see the prominent basal atypia on the background and the invasive keratinizing squamous cell carcinoma. And as the same as the biopsy, it maintains the basal overexpression in the invasive component. So it's important to understand that there exist different subtypes of vulvar intraepithelial lesions with different histologic, immunohistochemical, and more importantly, prognostic characteristics. And P16 and P53 should be used routinely for VIN, and understanding the diagnostic algorithm can help provide an accurate diagnosis for our patients. And here are my references, and anyone has any question?
I'd like to make some remarks if I can.
Yes, of course.
So the thing about differentiated VIN is the atypia, as you said, it's subtle, it's not that easy to see, especially if you're in training, but trust me, even for experienced pathologists that don't get to do enough GYN pathology, so general surgical pathologists, is difficult to see. So one thing that I heard in one lecture was a resident of I think it was Dr. Watkins who was holding that lecture, was saying the nuclei tend to look triangular. So the atypical basal and peribasal keratinocytes have these triangular looking nuclei. It's something that it's not specific, not typical of Devon, but it's something that it's that sort of Devon-like atypia that you would see. Apart from that, you mentioned at some point, you said, okay, if you see something that looks very basaloid and resembles squamous intraepithelial lesion, an H-cell of the cervix, you can instantly kind of think of HPV-related vulvar intraepithelial neoplasia, UVN. But the thing is that we have to kind of reflexive, that's my understanding of the thing, we have to kind of reflexively do P53 and P16, even if the morphology suggests something, because there are overlapping features in a sense that this is a typical Devon, yes, but you can have UVN-like Devon or basaloid type of Devon. And I've had a similar case. It helps when you look at patient age. People with UVN or UVN tends to more frequently occur in younger women than Devon. Devon is HPV independent, tends to occur more in older women in their 70s, 80s. So we had a case, 80-year-old female, had a grayish plaque, and the lesion looked exactly like a UVN. Like you could stick your hand in fire and say, this is a UVN. But doing P16 was negative, or there wasn't that block type positivity, and P53 showed complete loss. So, so this is one of the possibility of overlapping features, Devon looking like UVN. And there's the other possibility, the other way around, an irritated, a scratched, let's say, UVN may sort of differentiate in the sense that mechanical irritation leads to the epithelium acquiring more cytoplasm or pinkish cytoplasm, and it tends to look differentiated in a sense. It retains a sort of pseudomaturation towards the surface. So it can mimic, so UVN can mimic a Devon in this sense. It can look differentiated. So, and regarding complete loss of P53, one requirement, if you have, because you mentioned this is not a problem with the stain itself, that's one thing that you have to ask yourself when you see, because it's so rare, we usually expect overexpression. When you see complete loss of P53, the first thing you have to look for is to have an internal positive control, to see that the stain really worked. Because in your external control, it may have worked, but if it didn't work in the tissue itself, if you don't have normal epithelium, squamous epithelium around, that is, you have the scattered positive cells, then you may be wondering, is this real? Maybe want to repeat it or whatever. So this is one requirement for P53 loss, having internal positive control. Another thing about P53 wild type in UVN, that sort of basal sparing pattern that we see, it's pretty tricky because you really have to look where the P53 is staining. What are the cells? Where do they sit in the epithelium? The cells that are staining, to be able to say, okay, so the basal layer has nothing. It's negative, but the staining tends to occur in the mid layers. This is not necessarily specific, but it tends to be a bit more commonly seen in HPV-associated SIL, squamous intraepithelial lesion. So sometimes it may help. This is like a soft criterion that you may use. Sometimes it can help you if you have a vulvar lesion, a biopsy, and you have not that much material, where you're wondering, maybe it's inflamed, you're wondering if is it reactive or is it really dysplastic. You could, of course, P16 could help, but sometimes having this basal sparing sort of staining pattern is helpful in swaying you into saying, oh, this is dysplastic, because reactive epithelium will show mostly, of course, wild type P53, but the pattern will be more of that scattered basal nuclei that are positive, and not the basal sparing thing, which is more commonly seen in UVN. that were like the things that I wanted to comment.
Thank you so much, Miranda. Those were great remarks. And something I also wanted to add is that lichen sclerosus can have abnormal p53 expression, but without the atypia, there's no significance. So sometimes throwing a p53 to a tissue with no suspicion can be also like going down the tube sometimes.
Oh, definitely, yes. Yeah.
Yeah.
So it's more complicated than that, but you have to integrate everything into context,
Yeah.
clinical context, and morphology and immunohistochemical stains. So that's the conclusion of.
Yeah, definitely. Well, thank you again, everyone that attended.
Let's see. We have some questions. If atypia is vague, would you suggest doing PCC if any hyperkeratotic, acanthotic? Well, like I said, I don't see that much of these sort of pathology, so my experience is limited. Don't take my word for granted. But as I understand with these lesions, if you suspect that it is dysplastic, so we're not talking about, even if you're thinking, is it atypia or not, do the stains, do the P16, do the P53, because it's mostly gonna help in most instances. That's just my understanding of the whole thing. And I think if you would be kind enough to pass the post again to me, I would like to show you that case that I was saying of basaloid Devon, because I have it. So happens that I have it. Okay. Okay, so are you seeing my screen? I guess so, right? Yeah, so like I said, it was an 80-year-old something female with a gray-white vulvar plaque, and this is what we saw. Like we had this abrupt transition from normal squamous epithelium, which is always helpful regardless of the organ you're in, to like tips the scales towards dysplasia, not normal. Not that you would wonder if this is dysplastic or reactive. It's too much atypia to be only reactive and too little inflammation for that. But as a general idea, especially for those just starting their training, that an abrupt transition from normal to something that looks hyperchromatic, has increased NC ratio, loses maturation, as is in this example, is a very, very good clue that this is dysplasia and not some reactive lesion. We have enlarged nuclei, we have loss of maturation. The basal cells, the basal keratinocytes of the squamous epithelium, they are dysplastic and they atypical, and they look like they occupy the entire squamous epithelium. So we don't see those cells that have a lot more cytoplasm, eosinophilic, flattened nuclei, and so on. And to look a bit closer, this is what we saw. Like maybe you would argue that there is a sort of kind of a partially retained maturation in the cells, that in the sense that these the basal part of the epithelium does seem to be more blue than the upper portion. But overall, I think this is not something that you would look at and instantly think, oh, this is textbook differentiated VIN, right? So this is how it looked. And we had P53 loss, which is, again, what I've told you, always be sure that you have internal positive control. And this was the internal positive control in the epithelium. A bit too strong, I admit. But the basal layers, the basal cells, the most basal part of the epithelium only had scattered nuclei. With this magnification, is not that well visible. But the lesion at hand was completely negative for P53, right? And P16 was like wishy-washy, had nothing, interesting. So this is it. If nobody else has any other questions, this was a very short and quick and effective whirlwind through vulvar intraepithelial neoplasia. I hope you liked it. I enjoyed it. And especially I enjoyed the fact that you guys had the opportunity to present. And I would like this to be a thing, to be a common thing. We can make our regular meetings where I'll talk about stuff that we decide on our group, as we have done before. And if you want to present something, absolutely no worries, just say it. This is a place for you to have the chance to present in a very benign and very welcoming environment. Nobody is gonna judge you. So yeah, I hope you liked it, and I'll see you on our next meeting. Bye bye.
Thank you, Miruna. Great case.
Great cases, Felipe.
Thank you, everyone.